We're live.
We are live. Hi, everyone. Welcome to the September Group Insurance Commission meeting. It's crazy to think that the summer went by so fast. It's not technically over, but we are here at our September meeting, and we have got a great year ahead with a new procurement cycle, some new faces here at the GIC, and an opportunity to continue to serve our constituents. So I'm going to turn it over to Andrew. I'm Valerie Sullivan, I'm chair, and Andrew is going to let you know our commissioners here today.
Thank you, Madam Chair. In addition to the chair, we have our vice chair, Commissioner Kaplan, designee Govani, designee Butler, Commissioner Shabbat, Commissioner Chapdelaine, Commissioner Choate, Commissioner Kleinard, Commissioner Edmonds, Commissioner Gentile, Commissioner Guerin, Commissioner Jennings, Commissioner McEnany, Commissioner Sinenko, and Commissioner Timothy Sullivan. And we will be joined by Commissioner Murphy Rodriguez shortly.
Thank you, Andrew. So we have a very busy agenda here today with our executive director, and it'll start off with the executive director's report. But before we do that, let me take a motion. I know we've reviewed the minutes from our June meeting. We also went into executive session in April, so I'll need a motion to approve that report out as well. So let's start with the meeting minutes from June. Do we have discussion, or is there a motion?
I'll make the motion to accept the June meeting minutes.
Now second.
Okay, I do see Christy's hand is up. Christy, do you want to have a discussion about this before we take a vote?
Thanks, Valerie. Yeah, looking at the June 16th minutes, it mentioned about the EAP procurement that the vote was unanimous. And I actually think I abstained from that vote because of the materials. I hadn't had a chance to look at them. So I'm not positive, but that is my recollection. So I did want to make that comment about those minutes.
I think your
Chair.
recollection is close to mine as well, Christy. So thanks for bringing that up. Can we amend our motion to say that with those edits, we'll approve them, Andrew?
Yes, Commissioner Sullivan, just from Robert's Rules of Order standpoint, an abstention is not a vote. So it was unanimous of the voting members, which I believe is what it says. That was the reason that the abstentions were not recorded. The only time we need to record abstentions is if we are counting votes, and then they count as a no vote in that circumstance.
Thank you for that clarification, Andrew. So knowing that now, I'm fine with the minutes. Thank you.
Excellent. So I heard a motion by Bobby. I know we got a second. So I will go ahead and vote yes, aye, and then I will turn it over to Andrew to take roll call on the vote.
Thank you, Madam Chair. Commissioner Kaplan?
Yes.
Designee Butler?
Aye.
Commissioner Shabbat?
Yes.
Commissioner Chapdelaine?
Yes.
Commissioner Choate?
Yes.
Commissioner Kleinard?
Yes.
Commissioner Edmonds?
Yes.
Commissioner Gentile?
Yes.
Commissioner Guerin? I'll come back to you. Commissioner McEnany?
Yes.
Commissioner
Aye.
Jennings?
Yes.
Commissioner Sinenko?
Yes.
And Commissioner Tim Sullivan?
Yes.
Commissioner Guerin, do you have your audio back?
Yes.
Is that an affirmative vote? Commissioner Giron,
Yes.
thank you.
Yes.
The motion passes.
Thank you, Andrew. So we'll move on to the minutes from our executive session. It was actually in March. So I had the date wrong originally, as you can see here. I would like to request that those who are present at that session, if I could have a motion to approve those minutes as presented.
I'll make that motion to approve the March minutes from executive session.
Yes,
Second.
it sounded like that was a second from Jane Edmonds. So at this point, I will say I approve, and I will pass it over to Andrew for roll call.
Thank you, Madam Chair. Commissioner Kaplan,
Yes.
Designee Butler,
Yes.
Commissioner Shabbat,
Yes.
Commissioner Chapdelaine,
Yes.
Commissioner Choate,
No, I wasn't present, Andrew, at that executive session.
thank you. Commissioner Clenard,
Yes.
Commissioner Edmonds,
Yes.
Commissioner Gentile,
Yes.
Commissioner Giron,
Yes.
Commissioner Jennings,
Yes.
Commissioner McEnany,
Aye.
Commissioner Sinenko, Commissioner Sullivan,
Yes.
Commissioner Sinenko.
Yes.
Thank you. The motion passes.
All right, terrific. Thank you, Andrew. So at this point, I'll turn it over to our executive director, Matt Vino, and he'll take us through today's agenda.
Sorry, taking myself off mute. Thank you, Madam Chair. Thank you, members of the commission, those from the public, staff, and some of our guest presenters. Thank you all for joining us today. As was noted earlier, I really look forward to seeing you all in person. I had the pleasure of bumping into our vice chair on the sidewalk by the State House yesterday, and it was such a treat. So really look forward to seeing you all in person. So for today, just review the agenda briefly. In addition to our routine items, we have 3 topics to cover with you. We will have a presentation from our colleagues at CTI on this year's health plan audits. So for this cycle, just a reminder, we do this every 2 years for each of our carriers. So this year we have Harvard, Pilgrim, Tufts, and Always. We will also hear from our colleagues at Siegel, who are assisting us with the reprocurement of our all-important employee assistance program before we come back to you with a recommendation on a vendor. And finally, we will have Mike Berry from the GIC leadership team to present on the municipal health insurance market and how the GIC fits into that, a topic we've discussed a few times in the past. We know is an interest of commissioners. So with that, I will ask if we move on to the executive director's report. Thank you. So for the executive director's report, again, as per usual, we have provided you with a written report. I do want to turn it over to Brock Weidenheimer, our Director of Human Resources, to highlight a few items from his element of the report. Brock?
Yep. Thank you, Matt. Good morning, commissioners. I just would like to spend a few minutes providing a quick update on some recent staffing activity that has taken place within the GIC. And first, we've had a number of important changes in our IT organization. Following the retirement of John Harney, we've been working with the administration and finance IT leadership team to put in place a new leadership structure for the GIC. And we are very pleased that Stephanie Sutcliffe has accepted the position of CIO for the GIC. Stephanie, I think most people here probably know, she's been with the Commonwealth for over 34 years and has exceptional expertise in the IT field. She's most recently been serving as Director of Strategic Initiatives for the ANF IT organization, and in that role has worked very closely with the IT team at the GIC for a number of years, and has played a key role in the GIC's technology modernization initiatives. So in her new role, Stephanie will lead the overall IT organization for the GIC. And also on that team, we're pleased that Stephen Gerard has accepted the position of IT lead for the GIC, reporting to Stephanie. Steve's been part of the GIC IT team for over 7 years now and has played key roles in a number of the GIC technology enhancements. In his new expanded role, Steve will help Stephanie lead the team of application developers and analysts to support the GIC technology initiatives. And then on the final on the IT organization is that we're pleased to welcome a new face to the GIC IT team. And that's Kritika Gupta, who joined ANF IT's technology organization as a technology project manager recently. And her first roles, or first assignments with the Commonwealth are going to be working with the GIC as project manager on two important initiatives for us. The first is the next phase of the GIC Member Experience Transformation Initiative, and then also on a new program, the Zscaler Internet Security Project, which is an initiative to prevent any viruses, spam, or malicious software from infecting Commonwealth systems. So we're very pleased that Stephanie, Steve, and Kritika will be taking on these new roles and are very confident that we'll have very strong ongoing leadership for the important IT technology programs that will be ongoing at the GIC. And
Thank
then
you,
I'd
Brock.
also,
Go ahead. No, go ahead.
No, so I just very quickly was going to introduce three new employees and one returning employee in our operations department. Stephanie Medina joined the GIC about 3 weeks ago on our life insurance unit and transferred to the GIC from the State Retirement Board, where she had been a disability case manager. Christine Arsenault is joining us next Monday on the data entry unit and is coming to us from Leahy Hospital and Medical Center, where she's been a patient access specialist. And then Kristen Bent is going to join the GIC later this month on the Medicare enrollment unit. And she's coming from the Dimick Center in Boston and previously worked at Harvard Pilgrim Healthcare as well. And then the final note on the operations staffing front is that Donna Carbone, who recently retired after over 40 years with the GIC, has returned on a part-time basis as a post-retirement employee to work 2 days a week in the data entry unit and help support that unit while recruiting is underway to replace Donna's position and Lopes, who both retired this year. So that's the update I just wanted to provide. We do have a number of other open positions in the operations group that we are currently recruiting for, and we'll provide more updates as we move forward with those. So thanks, Matt. I'm sorry if I jumped in.
I see that Bobby has her hand up.
Yes,
And-
I just wanted to thank you, Valerie. I just wanted to quickly welcome everyone to the GIC, which is terrific, very close to my heart, not just because I'm vice chair, but I know a lot of people who've worked there. And Stephanie Sutcliffe I've known for a very long time, and many congratulations, Stephanie. It's terrific that you're going to be at the GIC. So congrats to everyone.
Yeah, I agree. I see Toby has his hand up. Go ahead, Toby. Nice to see you.
Yes, good morning. Brock, if this isn't the right time, it could be done later, but could you just comment on, are you having a difficult time attracting and recruiting people, or how's your retention holding up?
Yeah, no, thanks, Toby. It is more challenging than it was a couple of years ago. We're finding when we post positions, we're getting fewer applicants, and also finding that in some cases, even if we respond relatively quickly to set up interviews, we hear from the person that, well, thank you, but I've just accepted another job, somewhere else. So we are finding it, more challenging, but we're sort of reacting to that by trying to make sure we move quickly, that when we get positions posted, we get the interviews going quickly. And, the 3 new people just coming on, we're really excited about. We have other interviews that we're in the process, in the interview process with other candidates for different roles right now as well. So I think it is more challenging, but it seems to be, it's going okay.
Thank you.
Oh, yeah, that's great, Brock. Thank you. I wanted to ask just a clarifying question on our new IT leader, Stephanie. Is she reporting directly to us, or is it dotted line to A&F, or is it the opposite? And are there concerns about bandwidth if she has more responsibilities than just the GIC?
Yeah, so I'll take that one. So Stephanie and Steve are filling positions within A&F IT, which I think, as most commissioners know, they are embedded staff with us here at the GIC. We've worked very closely throughout, not just in the recruiting process, but just in terms of supervising staff that are really important to us that are not our staff. So they do continue to be under the A&F staffing, but they are very much an integral part of our team here. Frankly, I have no concerns about our ability to manage that, which in some respects is simply a figment of paperwork. These really are key members of our team, and they work closely with the operations team and others here. So,
Okay.
and I will say as well that when John Harney held this role for us, as he did for many years, John did also have a variety of responsibilities outside of the GIC for other A&F agencies. Working with A&F IT, we've tailored this position so that Stephanie is really completely dedicated to the GIC. So we've taken this opportunity to solve some of that, which has taken some managing in the past. So I think this is all good news. I think the fact that we have Stephanie and Steve, who have been part of this team and involved in our projects for a long time, is really reflective of how we've wanted to approach this, which is continuity. We have so much work going on in this space that is critical to our long-term objectives, and having people who they're not hitting the ground running, they were already on the ground running. So I think that brings a lot of value to us.
All right. Thank you, Matt. I appreciate the clarification. Let's keep moving.
So that's it for the executive director's report highlights. If there's any questions on other elements of the report, the written report that you received, we're happy to take those before we move on.
I don't see any, so we can move on.
Okay. So moving on to our calendar here, as you can see, for the remainder of the year, the team has been very busy this summer working on several important procurement recommendations to bring to you before the end of this year for approval and vote. And as you can see, we will have a vote on one or more procurements at each of our remaining meetings of the year. So we have a very busy season with the commission, but certainly on the staff level. In October, of course, we will vote on both the FSA procurement vendor selection and the medical benefit procurement. On the medical benefit, I just want to note that we look forward to getting to you all our procurement memo laying out our recommendation from the procurement team. We intend to have that to you at least a week before the October 20th meeting, and look forward to engaging with you all on its content before we meet for that commission vote. Along those same lines, I just want to remind each of our commissioners that you've signed a confidentiality agreement. This permits us to share this information with you in advance and does prohibit each of you from sharing that information with anyone else. So the integrity of the procurement depends on adherence to this agreement. As constraining as the rules will feel for you as they have for us, they really are necessary for us to conduct this procurement. And I thank you in advance for your cooperation on that. In November, the commission will vote on our EAP procurement vendor. Again, we'll be hearing a little bit more about that this morning. And in December, we will vote on the PBM procurement vendor. So that's all that's happening on the procurement side. In addition to all of that, our annual work, routine work continues, such as plan audits, which we'll discuss today. A report on our stewardship meetings with our health plans and PBMs, which we'll be doing in December. We will start the preliminary rate discussions either in November or December, depending on how that work proceeds. And then we will have our annual municipal update in December. So there's a lot going on. I want to thank the GIC team for all the hard work that they're already putting in place, that they're already doing to complete these procurements. And on the back end of these votes at the early start of 2023, we will have a different category of also really important work to prepare for our annual enrollment in the spring. So a lot going on. We appreciate all of your work and flexibility with us on these important matters. So happy to take any questions on any element of the calendar.
I don't see any. I know we have been preparing and been in discussions as a commission for several months about the procurement. So we appreciate you keeping us posted and communicating each month the progress. So your director's report is effective. No questions. Let's move on.
Thank you for that, Madam Chair. We can move on to our first presentation. I'd like to turn it over to Jim Rust to welcome our speaker for the health plan audits from CTI. Jim?
Thanks, Matt. Good morning, everyone. As you may recall from prior years, and as Matt mentioned, we audit our plans every other year. And today we have Michelle Succo from CTI, who performs the audits for our plans to present the results of the audits. I'd also like to mention that Catherine Moore, who is not here this morning, project manages that for the GIC and works closely with Michelle on doing these audits. And I'd also like to mention that the plans, as usual, cooperated fully in these audits, and we appreciate their efforts there because I know it's no small undertaking by CTI or the plans. With that, Michelle, I will turn it over to you.
Thank you, Jim. Good morning, everyone. Can you hear me okay? I'm seeing some heads nodding.
Yeah, but you could be a tiny bit louder, honestly.
Let me turn this up and move my speaker over a bit. Is that any better?
Much better. Thank you, Michelle.
Thank you. Thank you for the feedback. Okay. Do we have a driver that I can indicate when to move to the next slide?
Yes, you can let me know.
Thank you very much. Okay, let's go ahead and move into the PowerPoint presentation. As Jim mentioned, my name is Michelle Succo. I'm a vice president here at Clean Technologies Incorporated. We are located in Des Moines, Iowa. We have been your auditor for the last couple of audit cycles, and we are very pleased to represent your auditing needs. Today, I'm going to present audit results from the Always Health Partners, Harvard Pilgrim Healthcare, and Tufts Health Plan audits. As with the prior two year audits, these audits were performed remotely. We do not have any administrators that are allowing us to go on site yet and perform audits in person. So Once again, these were performed remotely, and as Jen mentioned, each of the carriers were very willing participants, very cooperative, and we really appreciate their collaboration. Next slide, please. The audit objectives were to determine whether or not each carrier followed the GIC contract terms, whether the claims were paid according to the plan documents and the provisions in those plan documents. We wanted to make sure that members were eligible and covered by a GIC plan at the time a service was incurred and paid. And then finally, if there was any claim administration, eligibility, maintenance systems, or processes that presented improvement opportunities, we noted that as well. Next slide, please. The audit components consist of a 200 claim random sample audit. As the name implies, this is purely a random sample. It is a statistically random sample with a confidence level of 95% plus or minus 3% bound, which is very common in our auditing industry. The second component, not to be confused with the random sample, is 100% electronic screening with 150 targeted sample analysis. We have our proprietary software that we call ESAS, ESAS. We have a number of predefined algorithms in place to make sure operationally that each carrier is performing its duties soundly, containing costs on behalf of self-funded plan sponsors, and just has some basic operational procedures in place to prevent duplicate claims from being paid, to manage high-cost claims, etc. In addition to those predefined algorithms, we also take each of your plans and custom code your limitations, exclusions, and your cost share, deductibles, copay, co-insurance, out-of-pocket maximums, etc. 100% of the claim universe for the audit period is run through all of these algorithms. Anything that breaks a rule presents itself on a report for our CTI auditors to target or select 150 claims. Now, I always give the auditors direction. If you have a $9,000 due and you have a $90 due, pick the $9,000 due. We want to pick in terms of materiality. The third component is data analytics. Again, we run 100% of the claims through our coding screening algorithms. We will independently assess and report on your provider discounts, correct coding initiative, the National Correct Coding Initiatives of procedure to procedure, medically unlikely, and ACA compliance, we will be reporting on as well. The fourth component is an extensive operational review questionnaire, which also includes management interviews with each of the operational areas for each of the carriers. And then finally, we are looking over your plan documents to make sure that your plans are clear, they are consistent. If there's any silent or ambiguous provisions, we will note those as well. Next slide, please. The audit period for these three carriers was fiscal year 2021. So any claim that was incurred during fiscal year 2021 and paid through year end 2021 was included in this universe of claims. On this slide, you can see for each of the carriers, the various plans that we audited, the amount paid by each of the carriers, and the total number of claims processed, paid, denied, adjusted. A final measure that we report on this slide is median claim turnaround. You can see that 2 of the 3 administrators had median claim turnaround time of 8 days, while Harvard Pilgrim had 12 days turnaround time. And then finally, I would just like to point out Tufts. Tufts had the largest amount paid, as well as the largest number of claims processed at just over $1.9 million or 1.9 million transactions. Next slide, please. We'll start with the random sample audit summary. Now, some of you may recall seeing this slide before, because all we do here at CTI are claim audits, and we do so many of these medical claim audits each and every year. We break the last 100 audits into quartiles with 25 administrator audits per quartile. The median on this slide represents the point at which 50 administrator audits falls above and 50 administrator audits fall below. Now, also what you're seeing on this slide is something that we are seeing as a trend in the industry with the majority of our audits. Always and Harvard Pilgrim actually performed poorer on this audit than they did 2 years ago. However, Tufts performed better. You will see that for the key performance indicators on the left, financial accuracy, accurate payment, accurate processing frequency, that both Always and Harvard Pilgrim fell below the median in all 3. Now, again, this is something that we are seeing in the industry with all of our administrator audits. This is not something that the GIC is experiencing with these 2 carriers alone. I don't know if it's because it's difficult to hire and train new staff. There have been, attrition issues throughout the last couple of years with COVID. Staff are working from home. However, what you are seeing on this slide is not unique to the GIC. I would like to remind everyone that all of CTI's audits come with 8 hours of post-audit follow-up for each carrier audit for a total of 24 hours. One of the things that we will be doing now that I'm presenting these results to the commission following this presentation is moving into the post-audit action planning. I will be creating a post-audit action plan for each of the 3 carriers, and I will be working with Catherine and the 3 carriers to make the audit results actionable and put together an actionable plan in an effort to improve these results and get results above median benchmark. I want to make it clear that that component has not happened. We will begin that component following today's presentation and work. Next slide, please. Always key findings. The random sample audit again consisted of 200 claims. Always had a financial accuracy rate of 98.02%, which equates to a 1.98% error rate. There were 12 claims identified with payment errors, totaling $26,807.97 in underpayments and $4,807.79 in overpayments. 9 of those 12 errors were adjudicated automatically by the system without any human intervention, and the remaining 3 errors were manually adjudicated. Anytime we see errors that were auto-adjudicated or processed without any human intervention as part of the random sample, we know that there are more errors that were impacted as a result of that system error or system configuration difficulty. So we always work with the administrators and ask that they perform root cause analysis to determine why was the error made, and then correct the systemic error. Finally, because there are more than just the 9 errors that occurred on the entire universe of claims, we ask that each administrator pull impact reports to identify all claims impacted as a result of the finding, and not just those that were flushed out through the 200 claim random sample. 16 claims in the 200 random sample were due to COVID-19 cost share being waived incorrectly, in our opinion. And let me just take a moment to explain. We definitely understand when COVID-19 first rose in March of 2020 and became prevalent and changed all of our working environments, that there were a lot of directives that were coming out. They were ever changing. And we recognized that administrators were doing the best that they could to keep up with the ever-changing environment as a result of COVID-19 and the pandemic. One of the things that the orders required was waiving cost share anytime there was testing. What we found with each of your 3 administrators during these audits was anytime there was a COVID-19 test, cost share was not just waived on that testing service, but it was waived on the entire claim. So virtually every single emergency room visit, hospital, inpatient hospital visit, surgical procedure required a COVID test prior to having an admittance or that surgical procedure performed. We saw, cases where there are non-COVID related services. There is no positive diagnosis of COVID on the claim, simply just a test. Yet each of your 3 administrators was waiving cost share on the entire claim. We do not believe the intent of those orders was when a woman goes in for maternity care and delivery and has a COVID-19 test performed prior to being admitted, that the cost share be waived on that entire bill. So again, there were 16 claims out of the 200, and you will see a recommendation on this later on in the presentation. For the 100% electronic screening with the target sampling, the 3 categories that presented the greatest improvement opportunities were payments for investigational and experimental treatment, incorrect primary care co-payments, and over accumulation of deductibles for both individual and family in-network claims. Next slide, please. Harvard-Pilgrim key findings. Again, for the random sample of 200 claims, Harvard-Pilgrim's financial accuracy rate was 96.41%, or a 3.59% error rate. We found 9 claims with payment errors totaling $22,816.61 in underpayments and $270 in overpayments. 6 of the 9 errors were auto-adjudicated without any human intervention. The remaining 3 were manually adjudicated. And as I previously shared, for those 6 system adjudicated claims, we will be working with Harvard-Pilgrim to perform root cause analysis, correct the system, and remediate by pulling impact reports on all impacted claims. And 7 of the 200 claims were for COVID-19 cost share waive incorrectly for the issue I just described. 100% electronic screening with targeted sampling. The categories for Harvard-Pilgrim that represent the greatest improvement opportunity is Medicare paid claims, Medicare eligible claims for members with end-stage renal disease, ESRD. We saw payments of physician assistants, nurse practitioners, and nurse surgery assistants paid in full rather than being reduced by the 80 to 90% that assistant surgeons are typically reduced by. In some cases, the nurse practitioner received greater reimbursement than the actual surgeon. Duplicate claim payments. And then finally, incorrect co-payments on primary care provider and inpatient facility claims. Now, again, each of these categories will be addressed as part of that post-audit remediation plan. Next slide, please. TUFS. Again, the random sample of 200 claims, the financial accuracy rate was 98.97%, which was the highest of the three carriers, 1.0% error rate. There were 8 claims identified with payment errors, totaling $817.73 in underpayments, $612.39 in overpayments. So again, although there were 8 errors, you can see that the overpayment and underpayments were significantly less than what you saw on the previous 2 slides. 3 of the 8 claims were auto-adjudicated without any human intervention, and 5 were manually adjudicated. 9 of the 200 claims were for COVID testing, where we believe cost share was made incorrectly. For the 100% screening with targeted sampling, the 3 categories that represent the greatest improvement opportunities are payments made in excess of billed charge. Again, we saw physician assistant, nurse practitioner, and nurse surgery assistants not being reduced by the 80 to 90% as typical in the industry. And we did find duplicate claims being paid. Next slide, please. In terms of recommendations for each of the 3 carriers, we recommend that the GIC meet with each of the administrators to discuss the audit findings, focusing on steps necessary to improve the key performance indicators that I previously shared. And again, for systemic financial errors, the administrators should run impact reports to identify and adjust all affected claims. The GIC should confirm with its administrators its agreement regarding COVID-19 claims and whether it should waive cost share on all service lines when a COVID-19 test was present on the claim. The administrators should conduct focused analysis of errors identified through our electronic screening to determine if overpayments and/or system improvements are possible to reduce or eliminate similar errors going forward. For that analysis, CTI will provide each administrator with claim detail to use in its analysis. The administrators should conduct a focused analysis of the National Correct Coding Initiative, procedure to procedure, and medically unlikely edit exceptions to identify code editing enhancement opportunities. The Center for Medicare and Medicaid Services, the largest payer in the nation, has adopted these National Correct Coding Initiatives that are available to everyone free of charge. Our stance is if the largest payer in the nation is not paying for a certain code combination or not paying more than X number of units on any given day, why would the self-funded clients that we represent want to pay for something that CMS, the largest payer in the nation, would not pay for? Again, this will be part of our post-audit action plan. Next slide, please. The administrator should conduct a focused analysis of the categories identified through preventive services where deductible and co-payments were applied. And again, we will provide additional detail to the administrators for use in their analysis as part of post-audit action planning. The GIC should verify fees owed to outside vendors used by each administrator, and confirm overpayment recovery fees are only charged for situations that are within the GIC's control, such as retroactive eligibility changes. We do not believe that the GIC should be charged commission or fees for carriers to recover monies for their mistakes or their erroneous payments. The GIC should implement authority limits requiring approval for any third-party liability lien reductions exceeding an agreed upon percentage. And then finally, this came up a couple of years ago, and we have made progress as a result of the post-audit work and the audit findings. All three of these administrators are now passing on all or part of the rebates associated with specialty drugs processed under the medical benefit coverage to the GIC. We are now taking it a step further because not all of the administrators are passing 100% through. So we've gotten them to pass through. Now we want to challenge them to pass through 100%. Next slide, please. Additional recommendations for Harvard Pilgrim only. We are recommending that Harvard Pilgrim review the results of its turnaround time reported on the randomly sampled claims to determine ways to reduce both the mean and the median turnaround time. You will recall on that summary slide that 2 of the administrators were at 8 days. Harvard Pilgrim was at 12 days. We at CTI like to see that measure at 10 days or less. Harvard Pilgrim should perform a focused review of its appeals handling, as it is overturning many more appeals than it is upholding. From a customer service standpoint, if you are always overturning a certain bucket of appeals, why not just pay those up front and avoid the process of appeals? So we will be having additional discussions with Harvard Pilgrim on that area as well. And then finally, for both Harvard Pilgrim and Tufts, we are recommending that the GIC update its plan booklets to clarify its intent for coverage of marriage counseling services. In the absence of an exclusion, administrators are covering marriage counseling services. Some of our clients exclude certain providers. Pastoral counseling, for example, is often excluded. So we are recommending that the GIC discuss its intent for coverage for marriage counseling and update and clarify its plan booklets accordingly. Next slide, please. That brings us to the end of the audit results presentation. I know I have provided a lot of information to you on 3 carrier audits in a short period of time. I want to thank you again for the opportunity to represent the GIC and its auditing needs. At this time, I would like to open it up for questions, and I do see a hand.
Go ahead, Bobby.
Yeah, sorry, I couldn't. I'm sorry about that. Michelle, I'm very much interested in, well, 2 things. One is the denial of appeals. I'm very curious if you know, are these denials of, let's say, surgical services or medical services? Do you have some idea of, and also the percentage of appeals that are denied?
Yeah, so we, as part of the operational review questionnaire, we asked for a copy of the appeals reports. We're looking to make sure that appeals are being handled timely. And then we're also calculating the upheld rate versus the overturn rate. It is not uncommon for CTI to see upheld rates ranging from 50 to about 67%. And we saw the inverse with about 67% of appeals being overturned as opposed to being upheld. And so that's why we want to dig into that further as part of that post-audit action planning. And you're absolutely on the right track, Bobby. We want to understand, are they surgical? Are they prior authorization? Is it out-of-network services? What categories are being upheld, or excuse me, overturned, and why? And again, if we're finding that those overturn rates in those particular categories are more commonly overturned than upheld, then perhaps the administrator needs to look at ways that it might change its current appeals handling and consider just paying for certain services up front. But that definitely does require some additional digging, if you will, and we will definitely include that as part of the post-audit action plan.
Great, thank you for that very much. Also, I wanted to ask you about the marriage counseling. So typically, I would think that would be that would fall under EAP, right? Counseling services. So could you perhaps provide a little more information on that or clarify it somewhat?
Sure. Yes, you're absolutely right. Oftentimes those services do fall under EAP. And if a EAP has a limit, oftentimes we might see an 8-visit limit for a particular service or condition. Once EAP has been exhausted, then it's common for it to go and move to medical plan coverage liability. There are definitions in your plan documents in terms of the provider, for a licensed therapist. However, it doesn't come out and specify that services have to be performed by a licensed professional in order to be covered. And so because there is that ambiguity, we are just recommending that you determine when you want to cover it and when you don't under the medical coverage.
Thank you very much for explaining that. I appreciate it.
You're welcome.
I don't see any other questions. I like your list of recommendations, Michelle. Little different audit report out than we've had previously, and I wonder if it's due to COVID and if you're seeing the same thing with other clients, that there's somewhat of a level of confusion about when it's covered and when it's not. So a really good granularity for us. Appreciate it.
Great.
So thank you.
Great.
So let's move on. Thank you.
Thank you.
Good morning,
Hey, Matt.
Commissioners. Oh, sorry. Go ahead, Matt.
Yeah, thank you, Michelle, for that presentation. We're very well served by CTI and the services that they bring, and want to thank Jim Rust, our CFO, among his many other responsibilities, for overseeing this and working with his staff. So at this point, I'd like to hand it over to Janine Dewar and the Siegel team for an update on the EAP procurement. Janine.
Thank you. Good morning, Commissioners. Siegel, our EAP consultant, has prepared an update on the EAP vendor procurement. And just as a reminder, because we are in the middle of this procurement, we may not be able to provide as much information as may be requested. It might be fairly limited. So before kicking it over to Siegel, I'd like to introduce the members from the account team. Stephen Kuhn is the Vice President, Health Consultant, Public Procurement Specialist, and Project Lead on this procurement. Lisa Bertola is the Senior Health Consultant, Behavioral Health Program Specialist, and Subject Matter Expert. So with that, I will kick it over to Siegel. Next slide, please.
Thank you, Janine. Also, Sarah Gunderson will be speaking for Siegel. She is a clinician and a subject matter expert with behavioral health. Again, thank you for having us. As Janine pointed out, this is a very high level
kind of review of the process and the program. We're being very sensitive to the fact that bids are due tomorrow, and we don't want to jeopardize that process. So I will go through the first couple slides to talk about the process and the timing, and then hand it over to Lisa and Sarah, the subject matter experts, to talk a little bit more of the program itself. And then we are certainly available to field any questions. Again, keeping in mind that we just want to be sensitive to the fact that proposals are due tomorrow. So looking at our process, you can see, again, proposals are due tomorrow. Then during the next few weeks, the GIC team and Siegel team will be evaluating proposals, selecting finalists, conducting the finalist interviews and reference checks towards the end of October, as well as getting best and final offers by the 28th of October. Then you will see us again with the GIC team presenting to you at the November meeting the recommendation of the vendor. Then during December, that will be the contracting phase and approval. And from there, next slide, please, the implementation process begins, of which during the next 6 months, there'll be implementation meetings with the selected vendor, the GIC team, and Siegel. There'll be the annual enrollment, in which meeting attendance of the new vendor for education purposes in April and May, and then the program will be effective on July 1st. With that, I'd like to hand it over to Lisa.
Great. Good morning, everyone. Thank you for having us. If we could advance to the next slide, that'd be great. So I'm going to spend a moment just to go over some of the key employee assistance program goals for this per procurement and some of the vendor criteria that we look for to meet those goals. It's a very timely benefit offering. So again, thank you for allowing us to help out with this. So the core services for employee assistance programs include short-term needs assessments, counseling, and referrals to other levels of care or to health plan offerings or community resources for people who need support. We look for, in terms of the vendor criteria to fulfill that service goal, ease of use, licensed credential professionals who have the appropriate professional certifications to deliver those services immediately at the point of access, with very little lag time between assessment and referral or giving a participant guidance on where to turn and what to do. That requires a certain training. We look for the really granular level of detail from the provider network and to see what the competence is of the providers who serve that role. We make sure also that the guidelines that their intake professionals and clinicians use are evidence-based, using screenings and other vetted tools to assess needs and deliver that service effectively. The other key program goal is to engage the GIC agencies and the participating employer groups, the municipalities and others, with the resources of the EAP. People think of the counseling, short-term assessment, and referral as kind of the main core service of an EAP, but there is also this training and critical incident response service that employee assistance program vendors provide. And that's been increasingly important industry-wide. It has been with your population as well, looking at the experience of the group. So that's another key program goal, to serve, to educate both internally within the GIC agencies and participating municipalities, key delegates, so that they understand what the resource is, when to trigger services, how to trigger services, and then deploy the right professionals for the moment and to serve the need. So again, with the GIC procurement, it's essential for the vendor to demonstrate the ability to meet diverse needs. You have many agencies. It's a complex, large organization a lot of different types of frontline workers and other types of workers and officials. It's a very mixed demographic group. So we need to find a vendor that can demonstrate experience and understanding and insights with each of those particular populations. And then the third key program goal is just to increase awareness and education about this resource and kind of work against the stigma of asking for help. You're seeing this in the news everywhere, but we're really looking specifically for, and Sarah will delve into this as well, we're looking for creative ways to engage people, to educate about how seeking support is actually a strength and a demonstration of resilience. So to do that, we look for a vendor that's going to partner with your internal resources. You have a human resource department that's very capable and used to doing this type of work already. You have an effective communications group team as well. So we're looking for a vendor that will partner with the GIC resources and leverage those resources in partnership with what they can offer to really engage, employees and household members to look at these resources and use them to keep their stress, their anxiety, their needs for work-life balance in good shape. So I'm going to now hand it off to my colleague, Sarah Gunderson, who is the clinical subject matter expert on this project. Unless there are any questions, I'm happy to take a question if there is any.
I don't see any questions.
Great. Thank you.
Oh, wait a minute, spoke too soon.
I know.
Bobby,
Yes,
go
you
ahead.
did. I'm sorry. I apologize. Lisa, I'm very curious about, we have had difficulty in the past sort of engaging people with EAP. So I'm very curious. I mean, it looks great. It sounds great, but how are you actually going to get people, because the utilization of EAP services is not what it should be, and particularly sort of since COVID, I would think that because I know firsthand what a lot of people need, but they're not. They sort of don't trust that. And I'm very curious how your approach is going to be different, and what are you going to do to encourage people,
That's a great question.
to take advantage of these services.
Right.
Just to be clear, Bobby,
Yes.
Siegel is our
I know.
consultant for the procurement, right?
No, I know
yeah,
that, but
yeah.
I wanted to know what their, maybe I should have phrased it differently. I know you the EAP vendor, right?
Yeah, I'm happy to take the question.
But I mean, what are you going to be looking for, right? You're our consultant in this, and you're going to be reviewing, vendors who provide these services. So what will you be looking for that will sort of make a difference? You know what I mean?
Bobby, I think what I'm hearing from you, and it's an important point, Matt, as experts in this area, how are you going to suss out what vendors we pick that are really going to commit to getting our people to use the EAP services?
Yeah,
I think
exactly.
that's what Bobby's saying.
Thank you, Valerie.
Yes. So we spend money in this area. There is some data. I don't know if it's hard data or qualitative data or just stereotypes that most EAP companies just kind of like bolt on free EAP or virtually free as a hook, but not really intending for high utilization. And maybe that's, sounds a little jarred from my years in healthcare. So.
Yeah, I understand the question. It's a good question. We did put questions and refine the RFR, the request for response proposals, to address in a very detailed way how the engagement would be improved. And we keep in mind all of the resources that are available to participants throughout the health plan offerings and within the GIC community, perhaps affiliations through unions or other collectively bargained agreements. So sometimes the utilization, it's okay, to have a utilization rate that's not what you think it should be if there are other access points, because it's common to put an EAP within a suite of offerings that's, a supplement to other offerings. So we keep that in mind. And as I mentioned, in terms of training and critical incident, those are important and increasingly important services that the EAP provides. And we've seen healthy engagement in those services. So rest assured, we have contributed content to the RFR to really get to that point, the engagement issue. Some of the challenges with engagement are from the participant side as well, just lack of, there is the stigma impact, the impact of stigma and concerns around privacy. So we very much target what the vendors can do in terms of assuring privacy, making sure that people feel that it's an easy access, that they're well matched with a provider, someone that they can relate to and resonate with. We look for vendor capability to do a little bit of profiling at the very beginning point of intake so that there's a good provider matching algorithm or program in place. Again, the confidentiality and privacy, those are key aspects of a good program to try to keep the engagement healthy. So we have contributed as the consultants on this to sharpen up and refine some of the questionnaire pieces of the RFR to get to that and to look for improvement. So in more work to come as we evaluate proposals, but I hope that helps answer your question. And it's a great point. It's front of mind for us as we evaluate the proposals. And we have more ideas on that topic as we continue to help the GIC.
Thank you.
Thank you. All right, let's keep moving. Want to stay on time.
I think we can advance the slide to the key Eap features, and I'll pass it over to Sarah Gunderson.
Great, thank you, Lisa. We just talked about the goals. Now we're going to talk about key features here. So first off, we're going to talk about measurable performance indicators. And this is a focus for us because we know that GIC values a vendor with transparency into the effectiveness of its programs and its outcomes. So for criteria, we're looking for good validation metrics. That's something that can stand on its own and can be used to evaluate whether the program is meeting the needs, getting appropriate engagement, and generating appropriate satisfaction for the people who use it. We're also looking for features, creative engagement platforms, and outreach. So as Lisa mentioned before, we'd like the vendors to illustrate how they can build on what is already existing, the current human resources and communications resources. So we're not creating duplicate work or poor value for the money that's going into this project, but so that the different resources can work together to effectively communicate, reach members, and make sure that those the GIC serves are aware and understand how to use the tools available to them. And lastly, for EAP features, this is really important. We want competitive financials and performance guarantees. We want to set expectations that the vendor will justify its fees with value. So we're looking for strategies like alignment of cost and utilization. So we're not just putting money into an EAP without seeing the results and understanding justification for those fees. And so some of the ways to do that also include like performance guarantees and being able to measure that performance and have fees at stake, fees at risk for that. So we're of course looking at more features than this, but to give that broad overview, understanding we're in the midst of this open bid right now. These are 3 important features that we're looking for.
Thank you, Sarah.
All right.
Any questions?
Yeah, I don't see any. So just remind us of next steps and what you're working on and how you're servicing our constituents with this consulting project.
So next steps are bids are due tomorrow.
Okay.
And the vote will be in November.
Okay, great. All right, thank you.
If I could just say one thing at the tail end. So first of all, thank you, Janine, and thank you to our colleagues at Siegel for this presentation. Janine, in addition to leading this procurement, does also lead on our pharmacy benefit procurement. So we're asking a lot of number of members of the team. So thank you for doing all that. I do just want to note, you know, it's come up in this discussion and actually as part of the audit discussion around marriage counselors. There is a natural overlap here between the services that the EAP provides to our members and to, in particular, some of the behavioral health benefits that are covered by our health plans. So I think I've said this before, and I just want to reiterate it here, that we are viewing both of these procurements, the health plan and the EAP, as an opportunity to really bring the strongest of both of those resources to bear for our members in a way that's not duplicative, but coordinated. So we viewed and approached both of these procurements with that in mind. So just wanted to add that in at the end.
Yeah, great. Really important for our members. So thank you, Matt. So, all right, we can move on. Thank you, Siegel.
All right, thank you all. So at this point, I want to hand it over to Mike Berry, our Director of Government Affairs, for a presentation on our municipal health insurance. At the last meeting, or a few of the last meetings, we had a few questions regarding municipalities and the GIC's work with them. In response to that, Mike has put together this presentation with some background and context for that work. This is not intended to be sort of a one and done opportunity to discuss our municipal business. As a reminder, we will be back with you in December to inform you of any municipal entities that have expressed a desire to join or to depart the GIC. But we felt it would be helpful at this point, given the interest, to provide some background detail on how we see and manage this part of our work. So with that, I'll hand it over to Mike.
Thank you, Matt. Good morning, commissioners. Lovely to see you all this morning. I have a few slides prepared for you that will provide some history regarding the municipal insurance program, as well as how our current portfolio of entities compares to the rest of the state. My hope today is that you'll come away with this presentation with a deeper understanding of the municipal marketplace and how GIC fits into that puzzle. Next slide, please. This slide is certainly my favorite and is a labor of love. I want to mention at the start of this that a huge debt of gratitude goes out to Sean Cronin, Deputy Commissioner of Local Services at DOR, and his team for helping put this together. We were able to map out 350 out of 351 cities and towns, and whether they are part of a purchasing group or whether they are independent and work directly with insurance carriers. As the multitude of colors on this map illustrates, the municipal insurance marketplace is vast, complex, and fragmented, with as many as 11 joint purchasing groups in operation, in addition to the GIC. Most of these purchasing groups, as you'll note from the colors, operate on a regional basis, but there are also more than 65 communities that work directly with insurance carriers and are therefore not part of any purchasing groups. One of the things that it's clear is that communities have no shortage of choices and options when it comes to where they obtain their employee health insurance coverage. Next slide. So we're going to get into a little bit here, the history of municipal insurance reform. So in 2007, the city of Springfield, this was actually prior to the inception of the municipal insurance program itself. The city of Springfield enrolled in the GIC as part of mandated restructuring to improve its financial health and budgetary stability. It was later that year that Governor Patrick signed into law legislation allowing municipalities to join the GIC with 70% approval of their Public Employee Committee, or PEC. Just for a minute, I'm just going to deviate just to define what a PEC is, because you'll hear that term a few times throughout this presentation. So a PEC is the designated insurance negotiating entity for unionized municipal employees and retirees. A PEC is composed of representatives of each collective bargaining unit with a weighted vote equal to its proportion among all benefit eligible employees. Retirees per statute are guaranteed one representative on every PEC with a 10% weighted vote.
So, hey, Mike.
Yes, Valerie. Madam Chair.
Could you, sorry, I am wondering if you wouldn't mind defining what a purchasing group is and, what's behind a purchasing group, unless you're getting to that.
No, I can tackle that one right now. So basically the laws governing municipal health insurance allow for joint purchase groups of, and this I don't have in front of me, it's either at least 2 communities or more or 3 communities or more. And they're allowed to join together for the purposes of group purchasing. And as part of that, they'll have a board of directors set up, usually a plan administrator, and they act almost like the GIC. In a way, and again,
yeah. And so if you could just go back to this slide for 1 second,
sure.
Beginning, where you have all this pretty salmon colored, the Hampshire County Group Insurance Trust.
Yeah.
All these communities bulked up and they put out a bid. So even though you have the pretty color for Blue Cross Blue Shield, 30 communities, is it fair to say that this salmon could also be serviced by Blue Cross, maybe as a TPA, because they're ultimately servicing the Hampshire County group purchasing?
Yeah, I don't have, I can confidently say that most of these purchasing groups offer multiple carriers. Certainly Blue Cross, Blue Shield is among them. Maya, for example, which is the darker blue, works exclusively with Blue Cross, but most of all the purchasing groups offer several carriers, and typically Blue Cross is certainly among them. I can't say that for all of them.
Great. No, that is what I wanted to understand, because I know we've historically talked, and Commissioner Tim Sullivan has been my educator on municipalities, and so I just wanted to, you're in agreement with everything he's taught me, but it's just clear that it's not as clear as it could be. How's that?
Yeah, and while we're on this, the orange communities are the GIC communities, and the one thing I should also point out is this doesn't obviously show regional school districts and where they receive coverage, but.
Yes, and I was referring to the salmon color, which is close to the orange color. So, so just to make sure I'm
sure
paying attention to you, Mike.
Yeah, no.
It's important.
No, that's okay.
All right, let's move on. Apologize for the
that's okay.
interruption.
So in 2011, the legislature amended the statute governing that allows GIC that allows cities and towns to join the GIC. And one of the sort of things they were responding to was the fact that from municipal managers felt that the 70% threshold was too high to achieve. So the legislature created two key reforms. One was allowing cities and towns to replicate GIC plan design without joining the GIC. You may have heard in prior presentations the GIC benchmark plan, and that allows cities and towns the ability to retain that local control, but replicating the plan design of GIC's greatest, highest enrolled plan. The other is a more management-friendly reform, which allows for, after proper notification, a 30-day negotiating window with the PEC if a financial analysis projects that GIC enrollment will produce a greater savings than plan design changes alone. And those were done in 2011, and we refer to them as sections 19 is the provision regarding the 70% threshold, and then sections 21 through 23 include those two reforms. In 2015, the last reform was made. So when a community joins the GIC, they must do so for a minimum of 3 years up to a maximum of 6. When that agreement expires, a town's enrollment in the GIC rolls over for a period of 2 years. The last legislative change to municipal health insurance came in 2015, when the rollover period for GIC renewal was shortened from 3 years to its current of 2. And where we are today, as we have been throughout the years, we continue to be a resource and partner for municipalities when it comes to evaluating their employee health insurance options. Next slide, please. You've seen this slide in the past. This just shows our current collection of cities and towns and regional school districts. I think one thing I added that we didn't necessarily include last time is the fact that our municipal employees make up just under 25% of all GIC subscribers. And you'll see on bottom just some other interesting factoids about our largest communities as well as our smallest. So we have a very, very broad cross-section of cities and towns, as well as gateway communities as well. Next slide. So this next one gets to, I think, one of the issues that commissioners have had questions on in the past. So in keeping with best financial management practices, most municipal entities routinely evaluate their health insurance options to ascertain that they're receiving the most favorable options possible. For communities in the GIC, this process begins with a written request for their medical claims data. This slide here discusses the data request process from the municipality's perspective. As you'll see, this process typically spans 4 to 6 months. The GIC's role in this process occurs at the very beginning when a community or school district requests their claims data in writing. Typically after that, are sort of concurrent with that, the school district or municipality will have an independent insurance consultant that'll be working with them to analyze their claim spending and premium data to develop what's called a medical loss ratio, or MLR. And once that loss ratio is determined, the insurance consultant is going back to meet with municipal officials and the PEC. And depending upon what that medical loss ratio is, they'll decide whether or not it's advantageous enough to issue an RFQ to insurance carriers or remain in the GIC. And this typically occurs over the summer. Where we are now, in August and early September, the RFQ by this time has typically been issued, and the PEC is reconvening to review the information, and if proposals from the insurance carriers show promise. In the fourth bullet, I qualify there, it's cost savings or potentially a different plan design or both. And if the PEC finds that that proposal is acceptable, they'll begin entering negotiations with that carrier. Once a final decision has been made, the municipality has until December 1st to notify the GIC of their intention for the following fiscal year. So a community that does not communicate anything to us one way or the other will automatically roll over for that 2-year period. Next slide, please. So this year, we received 11 claims data requests from a broad cross-section of communities, as you'll see. Again, the opportunity for a city or town to evaluate their health insurance options is an important one. But I think it's also important to say that just because a community requests their claims data, it's not necessarily a declaration of their intent to lead the GIC. In fact, just to use last year as an example, we had 13 data requests made last year, and that resulted in no departures. And I would be remiss if on this slide I did not also point out the team of Margaret Anschutz and specifically Lauren Makashima for their wonderful work in fulfilling these data requests and getting them turned around. This year it was a fantastic year, and I want to thank Margaret and Lauren for their assistance in getting all these requests completed. Next slide, please. So we'll sort of wrap up here. I know I just sort of ran through everything, but the GIC is a great option, but it really is just one of many insurance options for municipalities and regional school districts. And while I think we offer a great service, insurance coverage is a very localized process, as I'm sure Commissioner Sullivan could state as well. So the GIC is not designed to be able to sort of tailor its offerings and plan designed to meet all the needs of cities and towns in Massachusetts. So while we do not actively solicit business, we are always there to meet with any community, municipal official or PEC to talk about us in broad terms and help educate them about what GIC membership means and how we could potentially assist them in the future. So with that, commissioners, thank you for your time this morning, and I'm happy to answer any questions you may have.
Yeah, I'm pretty sure we're going to have a lot of questions here.
Great.
I see Christy has her hand up. Go, Christy.
Thanks. Just that last bullet point was contrary to what I thought I had heard a couple years ago. So about not soliciting business. Can you tell me what you do, I guess, as far as trying to get, I mean, do you send out letters? Do you market at all? Or do you just really wait back and wait for a town that's not involved with the GIC to come to you? If you could just clarify a little bit, I'd appreciate it. Thank you.
Sure. Thank you, Commissioner. It is definitely much more reactive, sort of being a public entity. We don't go out there and market ourselves. Most of the insurance consultants that work with these cities and towns are certainly well aware of the GIC, and on more than several occasions on behalf of prospective GIC community have reached out. And I've met with communities over the last several years that I've been here. So we're always there to sort of partner and serve as a resource, but we are not out there sort of beating the drum and putting ourselves out there. But most communities that want to entertain us certainly always receive a high level of responsiveness if they do want to learn more about us.
And Mike, is there another way that bullet could say the GIC is not proactively engaging with municipalities? We really don't have a strategy because of the reasons that you've outlined here, or the perceived barriers to working with municipalities.
I think, yeah, no, I think that's an accurate representation.
Okay.
Yeah.
I see Bobby had her hand up, and then Toby, you can go, and then Tim. I knew this would get a lot of discussion.
So, thanks, Mike, for that presentation. It was very informative. And I know that we don't or can't, actively go out and sort of solicit, but how, you know, other than sort of, you know, let's say word of mouth, or, you know, like how, because the coverage that we have, I think, for state employees is really quite good. And there is, you know, a savings. And I'm just curious, like, if we don't, like, what do we do, and how do we encourage municipalities to join the GIC, right? For their,
I think, you know, sort of an answer to your question, the fact that cities and towns can actually replicate plan design without joining the GIC is an attractive option for many. And one of the reasons being is because it allows that community to retain that local control. So, you know, for example, you know, a particular copay might be something that, you know, a community might want to have a very similar GIC plan design, but maybe, you know, with a top tier copay for a specialist to be $50 or something like that. So, you know, again, sort of going back to, you know, how sort of parochial Massachusetts is, a lot of communities, it's more important for them to have that local control. When you join the GIC, you do give up a reasonable amount, or you know, your sort of flexibility on plan design, and the only thing that's left to negotiate at the local level are the contribution ratios. So for a lot of cities and towns, there is that option to replicate our plan design while retaining that that local control. So
if I can just follow up to Mike on that one. Thank you, Mike. So I think one of the key points here is the first sentence of that second bullet, that municipal insurance coverage is an intensely localized process. And it's also driven by the unique circumstances of each municipality. And so, for instance, a municipality that has a more favorable risk pool than the GIC has, all other things being equal, would reasonably choose to have its own coverage directly with a carrier, or otherwise. I would say also, you know, folks here, I'm sure a number of folks here are very familiar with OPEB liabilities, other than pension employee benefits, right? So these are health insurance benefits, but there's a requirement over the last decade that they put a dollar figure to that obligation. And, you know, some municipalities are much further along in paying for that obligation. Others are less far along. So all of these unique local factors are really what drives a municipality to consider joining the GIC or not. And I think our evaluation is that being the case, an intense or more proactive effort on our part to market is not likely to yield much different of a result on the part of municipalities. But I think I'm eager to hear more from other commissioners here. I know this is maybe some different opinions on that, but that's where that's how we've evaluated it and developed the kind of posture that we have.
So let's hear from Toby next. I know he was looking for some time, and then I know Tim got your hand up as well.
Okay, I think I'm a broken record on this, but I don't understand, especially while there's a similar benefit plan, like we just don't blow them away on the price. We're the big gorilla. I just don't understand that. I don't expect you to answer that because I've asked it before, and that's number one.
And maybe Toby, before you go off of that, do you ever get a chance to compare our rates to what they're getting at the municipal level in order to show them that, or does the conversation never progress to showing our rate costs?
Sure. One of the things that I've learned from this process is it's very difficult to compare GIC plan design to a community that is not in the GIC. And the reason being, as you know, that what goes into the premiums are the particular networks, co-pays, and everything else. And, you know, at some point in an earlier version, I did try and look at doing a comparison, but it was just too difficult to compare their premiums to our premiums because there's so much that goes into that premium. And that's really at the local level where the independent insurance consultant comes in to help sort of answer those questions with the community. So I can certainly understand your question, Toby and Valerie, but there's so much that goes in to that price. It's often very difficult to compare on the surface and requires quite a lot of
Sure, but they're doing it to you. The insurance consultant's doing it to you. They're comparing somebody's cost. And I understand sometimes cost is not the key driver, and it's politics, and I understand all that stuff. And I'm just saying is I don't accept that, but I don't want to debate it. The other is, do you track once somebody joins? Do you track do you calculate on a periodic basis and track the medical loss ratio so that we know where they're trending and we can communicate to them and things like that?
No, we don't. It's probably a question for Jim or somebody, but one of the things that we do discuss with municipalities is the fact that we actually don't track their medical loss ratio. So we're one big insurance pool, and for a lot of communities that is attractive. The fact that if they have a bad year, they're not going to get hit with, you know, an unexpected increase. So that is one of the things that we do tell communities is a benefit of GIC membership that might be different than when they work with a carrier directly. So,
okay, thank you.
And if I could add real quick to that, we do have the ability, of course, to cut the data and look at the various towns, but it's not something that we do in order to assess a town's performance, if you will, but we do have the data and we do run it.
So how about you, Tim?
Thank you for the presentation. Just have a quick question. In terms of the slide where you talked about the law and the different reforms that came about after the law was originally passed, one of them was the 30-day issue. And just like to, there is 30 days of expedited bargaining. At the end of those 30 days, if there is no agreement, then the municipality can actually force the unions into the GIC. And I'm just curious, out of the municipalities that are part of the GIC currently, in terms of the slide that you put out there, do you know of any, what the number is in terms of unions that went through the expedited bargaining and didn't reach agreement at the end and may have been forced into the GIC? I'm just curious as to whether we have any numbers on that.
Thank you, Commissioner. I'm sure we could certainly get that figure for you. One of the things that when a community sort of joins the GIC, we don't typically pay too much attention to the manner in which they came, but we do require communities to submit their PEC agreements, and oftentimes that'll dictate how that happens. So we could certainly look into that. I would venture to guess that the majority of communities at this point came in through that 2011 reform, but I don't have the specific breakdown.
Sure. I just think it would be a good learning tool for us. If there were those who were forced in, what are the reasons why they were forced in, and see if there's something we could do to bridge that, to encourage more to come in if it is a better deal.
And the one thing I'll add on that is that there was also mitigation in there. So if with a community sort of being forced to join the GIC, one of the things that the law requires, and there were so many different components of the law that we could have shared, but in the interest of brevity, tried condensing it. But communities are required to set aside 25% of the savings from joining the GIC. That's typically involves setting up a healthcare trust fund that will be used to mitigate any cost impacts. And I know for a lot of communities, the savings have been significant where that trust fund has lasted several years. So,
Thank you.
All right, I see, I thought I saw some other hands up. I thought I saw Adam, your hand up. Do you have a comment or a question?
Yes, thank you. And thanks to Mike and the team for putting this on. I raised my hand when Toby was asking about why more communities haven't likely gone in. And I actually think Commissioner Sullivan just spoke to that. And Toby had mentioned there is a political part of this. And I think that's true. I mean, in Arlington, we went in 2012, really directly on the heels of that 2011 legislative change. And I can tell you from both a political and administrative point of view, it was probably the hardest thing I ever did in my career because of the, at times legitimate emotional attachment that people have to their health insurance. So it gets very dynamic with being able to access that 2011 change does require your elected select board in towns, and I believe city councils and cities, to vote to authorize the usage of that section of legislation to then allow the administration of the town or city to go forward and begin that process of potentially, again, to use the word like Tim used, forcing employees into the GIC. And if people are quite anxious, worried, upset about that change, getting that vote out of the elected body can be very challenging. Back in 2012, when a good handful of communities went in, the savings were extraordinary. My sense is that markets have tightened or margins have tightened since then, and the savings are probably still there for some communities, but not as extraordinary. And if there aren't extraordinary savings there to present to employees and then share with them at that 25% rate that Mike mentioned, it can be hard to overcome concerns people have about network mapping they do in determining whether or not their specialists that their family or they currently see will still be covered in the GIC. So I am a big fan of promoting people to look at the GIC. I think it's easier to administer from a local point of view. It's more there's always more options in the GIC than what you'll have at the local level. Usually at the local level, you'll have one, maybe if you're lucky, two options. The GIC obviously has far more than that, but it's still a hurdle to get there when you're dealing with people and their concerns about their healthcare.
No, thank you, Adam. We know you're, schooled in this, and we appreciate that you took the initiative to join the GIC, and I know that your municipality is benefiting from it. So everything is hard until it becomes easy. Glad that you had a good experience with us. Hey, I see that Joe also had his hand up. Joe, we love hearing from you if you still have a question or comment.
Yes, and you don't hear from me very often. So, so great presentation. I don't want to kind of say what Tim and Adam just said. What I will say is in 2007, I was vice president of my union in Springfield when that change was made. And for us, the GIC became a great option because we had had our health insurance changed by the employer without bargaining. So it became a great option for us. And I think that's what the GIC is. We're here as an option, but for many communities, they have very good insurance. And like Adam was saying, when you have great insurance, you're not looking to change. So it's going to be something that is here for the groups that want to come, but I don't think we should be pushing anybody to come in. And that's all.
I don't think there's a unanimous view on municipalities, and I think that's okay across our commissioner group because, I heard from Bobby, like, we're so great, the GIC, why doesn't everyone want to come in? And if we got everybody in, I think people like Christy are thinking, then, we'd have more power to negotiate with the insurance companies. Our members would get lower costs, and our job is to advocate for our constituents and ensure they're getting the very best coverage for the very lowest price. And we think this is a great way to do it by getting everyone in the state of Massachusetts to be part of the GIC. But at the same time, we're hearing things from Tim and Adam, and of course, Mike, you're the messenger pulling this all together. So I think to the degree that we can, as a commission, be as responsive to the folks who come in. So if you go back to that slide, Mike, the ones who asked us for data this year, if we can be as responsive to these folks, and if any of these folks are listening, call any one of us for a recommendation and get these 16,312 members in so that they can enjoy the benefits Bobby spoke of. I feel like it may be a good place to move forward with. And Bobby, do you still have a question? Do you want to debate?
Yes, I do. No, I don't want to debate it anymore and hold everyone up. But I would, Adam, I wanted to thank Adam and Tim particularly for explaining. It made it much clearer to me, sort of the reasons why. I was a member of the OPEB board for the town of Brookline when they were negotiating with all their unions, whether or not to join the GIC. And so, I understand firsthand experience of how difficult it is, but the benefits are so great. And this is going back to, I want to say like 2009, I think Brookline joined, but it is very difficult. But I think we have to think about a concerted, approach perhaps to this, because, if we're just one of, 20 options, we're not going to be noticed, right? So, it's about aside from the great insurance carriers, so many different options, it's also a savings for people. And the more people, as you said, Valerie, that join, right, the bigger the voice, the more power that we have to negotiate. So I appreciate Adam very much, and Tim, not that I don't appreciate your comments, Joe, but I really appreciate your explanation and making it much easier to understand, because it's a very complicated issue and obviously a political one as well. So thank you again.
And we know, Mike, that you're taking in all these comments and proactively working with municipalities who are expressing interest, as well as supporting those municipalities who are part of us. So keep up the good work there. This was a good presentation. I suspect we'll continue to have dialogue on this, as it's an important issue, an area from a leverage perspective. If we can get in more lives, we have more power, and that really helps our members. So you guys get it. Let's move on. Thank you, everyone. Loved the discussion. We've got to continue to do more of it. It's a topic that you can see gets our commissioners, really engaged. So thank you, Mike. So let's move on. Jim, you're always the one that has to rush us through to get us on time. We know what a good job you do keeping us on budget. So, and you do so many other things with procurement. So thank you, thank you, thank you. You're up.
Thank you. I appreciate it. And this is a pretty brief presentation. We just wanted to talk about the end of the FY22 budget year, which ended on 6/30. As you know, we usually give a wrap up in September, and I can be pretty brief since you have the materials. Next slide, please. This is a slide that you've seen before. We keep tracking the medical claims since COVID's inception, and we see nothing really new here either. The claims continue to rise towards where they were in the pre-COVID level, but there's a lot of volatility around this. as we go through waves of cases and things like that. So not a new message here, but we continue to see the same trend. Next slide, please. And we continue to track our COVID claims by month to see how much we're spending on COVID. And a point I will make here, you can read the information, so I won't read it to you, is that some of the changes you see among time is as treatments come on, that becomes a COVID claim, right? As different treatments come online, and then as the cases come up and down, it causes a lot of volatility here as well. But we do keep a track of it in the accounting system, so we know what we are spending on COVID claims.
So, hey, Jim.
Yes.
I see Toby has his hand up.
Oh, sure. Thank you.
Toby, go ahead.
Yeah, quick question, Jim, is on the COVID claims. What we heard in the audit was that some of the claims that they were in their sample, once they did a test, they coded everything as COVID.
Yeah.
Kind of is another reason why, I mean, it's not going to impact the medical claims. I understand that.
Yeah.
And another reason why it kind of stays up there, because they get, you go into a hospital, everybody gets a COVID test.
Right. And this is something, as Michelle mentioned, that we also noticed in the audit, and we want to go back to the plans, and we're going to rerun a lot of this to make sure that it's being adjudicated correctly now. But it would put upward pressure on this, and we are going to look at it to try to get a sense of the bounds around this to see how many claims and how much money was involved in that kind of thing. But it should also be noted that that was around cost share, right? So it's not every dollar we would have paid a large amount of some of those claims anyway, right? But it does the bias does bring it up. You're absolutely right, and we are going to look at that. I'd also like to get my hands around that.
Yeah, my point was it's not going to probably, because it's cost share, influence the bottom line. I understand that, but it more kind of informs why that it may inform why that we continue to see the allocation to COVID of the kind of the same number until June.
Correct. Yeah, it would definitely bias things in that direction, and along with a lot of other moving parts here, but it is one of them.
Yeah,
sure.
And another moving parts. Yeah, gotcha. Thank you.
Thank you. Next slide, please. So this is informational. We like to show you the claims by month to our vendors, so you get a sense of where the funds allocated by the Commonwealth go. And if we look at the next slide, and this is the share of the same vendors and the money that comes from the employee side, and where those go to pay claims and premiums. So this is the whole year. So you see this slide builds up over the course of the year, as you know. Next slide, please. And here's kind of the bottom line on a line graph that shows the shape of the budget, the way we projected it at the beginning of the year and the way that it turned out. And the shape was pretty spot on this year. I give kudos as usual to Catherine Moore, who spends a lot of time trying to project our month-to-month claims. And although there is some variation, the shape of the spending was more or less as we predicted it would be. Next slide, please. And fine, this is the cumulative budget. And as you know, I like this slide because it shows, although we do have variation from budget, the enormity of our budget, the variation is very small. So the lines of the projected and the actual spend are pretty much right on top of each other. And last slide, please. And finally, here are the numbers behind the graphs. As you can see, actually, I can only see me, not the numbers. Okay, there we go. I moved me. We came in under budget at about $55 million under budget, which is 2.3%. And that is basically the same parameters we've had the last few years, where we've been 3% or less under budget. So that's how the year ended. Sorry. Any questions on this? I'm happy to answer them.
Good
So
job budgeting. That's great, Jim. Thanks. Is that Jane? Did you ask a question? Is that Bobby?
Yes, that was me. Sorry. Okay. I just wanted to know so that dollar amount went back to the general fund. Is that it?
Correct. Yes. Any money not spent from the appropriation goes back to the general fund.
Right. So that was the 57. Right?
Yeah, the 55.
Is that correct?
Right.
55, right,
55.
sorry. 55 million went back to the general fund.
Correct.
All right, thank you. I just wanted to confirm that.
Yep, thank you. I should have mentioned that. Appreciate it.
Eileen, go ahead. So you have a question.
I just wanted to say kudos. To project that accurately on a budget that size is pretty impressive. So good work.
Oh, thank you very much. And again, I can't stress that Catherine Moore and her team also spend a lot of time in this. I know we don't hear from Catherine directly as much, but she will also present on the budget. But thank you very much.
Thank you. All right, Executive Director Matt Vino. We got any other business?
Thank you, Madam Chair. That concludes our agenda for the day, 3 minutes before close. So thank you all for participating in the meeting today, for the really rich discussion, I think, particularly around municipalities and our EAP. These are all very important aspects of our work, and your feedback and guidance on them, as always, is very much appreciated. So with that, I think we simply have any old or new business as our final item. So turn it back to you.
I see, Bobby, you have your hand up.
Yes,
Is there?
I just wanted to say one more thing. I wanted to thank Mike and Jim for their terrific presentations today. It was, as Matt said, very rich discussion. It was a great way to start the year, right?
Yes.
It was great. So thank you all. Thank all the staff who I forgot to mention, or I didn't mention, I should say, for all the hard work that's been done for this meeting.
Yes,
So thank you
Bobby.
again. And thank
Yes,
you, Matt,
Bobby.
as well.
Yes, it's great to have the discussion and the dialogue among commissioners. I know it's hard on Zoom, but I want to thank the commissioners who are on the board, who spend their mornings on Thursday in front of a camera. Matt, we probably all would ask that we, as Bobby opened up this meeting, we'd like to get back together. And so maybe we can have a target goal of December or January, rather, to kick off the new year. But at this point, I don't see any other hands up. It's been a good meeting. Thanks to everyone. Have a good September. And remember, our October meeting is voting procurement. It's confidential. The staff has a really hard time. We've got to do our duties as commissioners and abide by the rules set forth by the state. So we'll see you in October. And with the power vested in me, this meeting is adjourned. Bye, everyone.
Thank you all.
Thank you. Thanks. Have a good one.